Welcome everybody to the webinar. I'm Dr. Robert Amler. I'm Dean of the School of Health Sciences and Practice here at New York Medical College. You are in for a treat this evening because we have, backed by popular demand from prior Touro webinars, we have Dr. Kathleen DiCaprio. Everybody gave her the highest possible marks during her briefer comments on the prospects for vaccine and other comments on our ability to conquer this terrible coronavirus COVID-19 outbreak. A couple words about Dr. DiCaprio. She is Assistant Professor of Medical Microbiology and Immunology at the Touro College of Osteopathic Medicine. She earned her Ph.D. in Pathology at the Uniformed Services University of the Health Sciences. She also is a Kaplan USMLE Step 1 instructor for immunology and microbiology. Previously, she worked for the New York City Department of Health and Mental Hygiene Public Health Laboratory, where she assisted in laboratory and emergency responses during the H1N1 influenza outbreak in 2009. Do you all remember that horrible outbreak that came upon us in the late spring and took everybody by surprise? Dr. DiCaprio also serves as a consultant in areas of laboratory biosafety, emergency responses, and animal laboratory sciences for Boston University's National Emerging Infectious Disease Laboratories. Probably of greatest interest and excitement, Dr. DiCaprio in 2005 helped develop a vaccine now being tested by the National Institutes of Health, which is considered the best hope to stem the spread of the Ebola virus. Remember that one, it hasn't gone away. So we really feel privileged to have you here. She agreed to do this on incredibly short notice amid an avalanche of vaccine news that continues to pour in even today. Without further ado, Dr. DiCaprio, who is going to speak now about the vaccines against COVID-19 and the prospect for more vaccines. Dr. DiCaprio, welcome to the webinar, and thank you for joining us.
Oh, thank you so much for having me. Everyone, welcome. I'm so glad to see everyone joining this webinar. It's my pleasure to be here to provide any answers that I can. Some of the more common questions. For many of you, you may just be joining to just gather some information, and that's great. And it's totally fine. I mean, this is new. This is historic what we're going through right now. Not only is this a historic pandemic, very unfortunate one, but what we're seeing in terms of vaccine development, therapeutic developments, diagnostic developments, this really is a historic point in our scientific and medicine times, to just kind of be sponges. And for many of you out there, you're medical students, you're graduate students, you're undergraduate students, and this is a great time to just kind of get some information. And for many of you, you're also just curious about whether or not this is safe for you. As a mother of 3 and as a wife, I'm also looking at that at myself for my family. So let's take a look at what we know. So what I'm going to do is just talk a little bit about some of the vaccines that are out there. All right. And then I'm just going to go over a handful of questions that have been really the most common questions I've received over the last couple of weeks, some more than others, but hopefully that will help give you guys a good foundation. And then I'll take any additional questions that you have. Hopefully I'll be able to answer them. Some I may not be, mostly because we just don't have a lot of information on some of this stuff yet. But I do want to start off by just kind of reminding everyone that December 14th, first COVID-19 vaccine. Do you believe it? We've been in this pandemic for how long? I don't even know. I haven't left this room. Oh my goodness. I can tell you, I'm so glad my kids are in school though. There's no amount of money that I wouldn't have paid to just have gotten them out of here. So I was pretty happy about that. But it's amazing to know how, just to think about how long this has been. But our first vaccination in the United States was just a few days ago. So it's pretty amazing to see everything that went into this. So just to kind of get started, to give you guys a landscape of what we have, there are several vaccines that are out there right now, but of those, we have 4 top candidates. The first is the Pfizer vaccine. That's the one that's been approved, that is actively being given right now in the United States and elsewhere across the globe. All right, next up, all right, and just what's the date today? Today is the 16th. So in 24 to 48 hours, we will know if the Morderna vaccine, also an mRNA vaccine, if it will be approved, and it will also quickly be deployed and available for our healthcare workers and our high-risk populations. All right, and so we're going to talk mostly about those vaccines today, but I also want to introduce you guys and also be available to answer questions on the other 2 vaccines, which are a little bit different. The Johnson & Johnson vaccine, all right, this one is also looks very promising and is a very interesting vaccine. That one is an adenoviral vector vaccine. We'll talk a little bit about that. That one is in active phase 3 trials across the United States, and we're hoping to get some initial data on phase 3 safe. We already know the safety data looks very good, but more looking at the efficacy. Does it work? Does it not work? We're looking for that data to come in probably sometime in January. Now, the Astrazeneca vaccine is interesting. We'll talk about that one as well, just briefly, because that one did release some of its efficacy data a few weeks ago, but its dosing schedules were a little off. And so that one, we're just gonna have to wait a little bit longer for that one, because the trial itself had its 2 doses at a certain concentration, but there was an error, and the first dose actually was given at a half dose. And surprisingly, guess what? That half dose worked better than the full dose. So they've got to go back and review some of that, maybe do a couple of additional amendments to their phase 3 trial before we can move forward with that one. But that one also looks very promising. So what you see here, guys, 4 vaccines in record time that are likely going to move forward with an emergency use authorization in the next couple of months. One of them already, one hopefully we get in 48 hours, and the other 2 in the next month or 2. So let's talk a little bit about these, okay? Now, before we do, I just want to make sure everyone has this understanding of what an emergency use authorization is, because that is what these vaccines are being approved of. You might hear in a news article or in a conversation, or even a reporter talking about how these vaccines are not yet approved, but yet they're being given. I can see how it gets confusing. Understand that for the FDA wants to approve a vaccine to be fully licensed. That is an approved vaccine. But there are circumstances such as COVID-19. There are these exceptions where the FDA has this mechanism through an emergency use authorization to facilitate the availability and use of medical countermeasures, including vaccines such as these, during public health emergencies, such as COVID-19 pandemic. Clearly, this is an emergency. And so they're using this mechanism to push forward these vaccines as long as they are deemed safe and effective. Those are very important terms that we need to kind of understand. They have deemed these vaccines, the Pfizer so far, the Moderna is going to be reviewed next tomorrow, safe and effective. By doing that, they are weighing out the potential benefits against the potential risks. And that is what they're looking at. Not only is the FDA, but an advisory group of independent scientists are doing that as well. That is the top scientists and the FDA. There's a lot of amazing, bright people in our country that are reviewing these to evaluate the safety and the efficacy. All right. And what they're doing as far as the emergency use authorization goes is against a primary efficacy endpoint. What the heck is that? All right. What they're doing is they're looking to see, are these vaccines going to prevent the disease and the infection? Those are when we look at there's lots of endpoints that these clinical trials are looking at, but the big one that they're all looking at, is it going to prevent disease, whether it be severe disease, sickness, or infection? And that is the primary kind of goal, objective endpoint that these studies are weighing against. There's lots of other things that these trials are looking at, guys. They're looking at, is 1 dose good? Is 2 doses okay? When do we need to get this? Can we do it in children? Can we do it in immunocompromised individuals? There's lots of things that they're looking at. But as far as this EUA is looking at, is it going to prevent infection and severe disease? All right, so there's lots of data that's going to be coming out over the next several months. But for now, this is what we know. All right, most important, they're looking at the safety data. They're looking at all the data from phase 1 and phase 2. Clinical trials are 3 phases. They're looking at it all. And then they're looking at what they're getting from phase 3. Phase 3, after the recipients receive if it's 1 dose, after that dose, if it's 2 doses after the second dose, they're going to follow those participants at least 2 months out. All right. And so they can't do anything until 2 months out. So all of these vaccines, at least 2 months after the last dose that they get, they're evaluating all of that data that they're getting, so that you guys have it, just so that you have an idea of what this EUA is, and kind of all the data that they're looking at. So the big questions that I'm getting right now is, what is an mRNA vaccine? This is a new technology, and how does it work? Well, basically, for those of you that have a little bit of a background in some sciences, remember that messenger RNA, all right, that is going to translate to give us protein. So those are instructions to give us proteins. And it's the proteins of the virus that our immune response is going to generate against. Those proteins are the targets. And with COVID-19 or SARS-CoV-2, the target is this spike protein. All right. And these mRNA vaccines, they have small pieces of mRNA that encode the spike protein. So what they do is they have these little sequences, these mRNA sequences, and they coat them with these lipid coatings, and they make these nanoparticles. And that is what the vaccine is. So in that vial, that's what we have. We have all these little nanoparticles with mRNA inside of them. So when the patient gets that vaccine, all right, those nanoparticles will go in the system, and those little lipids will fuse with our cellular membranes, and the mRNA will get injected into the cytoplasm. And our ribosomes see that mRNA and say, oh, that's just a piece of mRNA, and my job is to make a protein. The ribosomes don't know any different. So the ribosomes jump on that piece of messenger RNA and encodes the spike protein. Okay, we kind of trick ourselves into just thinking it's regular mRNA. And the spike proteins are made from SARS coronavirus 2, and they just stick up on the surface of our cells. And our immune systems see them as such. And they say, oh, that's a foreign protein. We better generate an immune response to that. And so our T cells get activated, our B cells get activated and make antibodies. And that's it. That's all that it is. It's a very simple way of just kind of following through with the central dogma of our normal biology, and we'll generate an immune response to that spike protein. Now, the spike proteins we know are very important. And so those are really what we want the immune response to target. So the Morderna and the Pfizer vaccines have taken the mRNA sequences of the spike proteins, coated those in those lipids or nanoparticles, and that's what we're getting in the vaccine. That is what is in the vaccine that we get with the Pfizer and the Morderna. Okay, where's my mouse here? Okay, so how does this differ from other vaccines that we've had? All right, we talk about how this mRNA vaccine is very new. It's new. This is a new technology. But guys, we've been studying this technology for many years. This technology has been studied in making other vaccines, an experimental vaccine for Zika, an experimental vaccine for other viruses, even experimental vaccines and technologies against cancer. So we've been working with this technology for many years now. Only now, because of the pandemic, has this vaccine for COVID-19 been a little bit expedited. But the mRNA vaccine technology has been studied for a while now. Now, the existing vaccines that we have to the flu virus, measles, mumps, and rubella, polio, these are a little bit different. A lot of these vaccines will either take those viruses, those pathogens, and kill them. Okay, so they're like frozen. All right, we treat them with certain chemicals. All right, and they're just frozen pieces of the vaccine, and that's what we inject inside of our that's the injections that we get or our patients get. And those are not going to replicate. They're not going to do anything. They're just frozen pieces of the virus, and the immune system will see them as foreign and generate an immune system. We also have what we call attenuated or weakened versions of pathogens. And this is like the measles, mumps, rubella vaccine, for example. And these are weakened. So when we get these vaccines, these viruses are alive. These vaccines are alive, but they're so weak that when we get them and they start to replicate and produce some of these viral proteins, okay, it's not enough to make us sick. All right, some of us might get a little fever, some of these side effects that we hear about, fatigue, malaise, okay, but that's our immune system generating a response against those. So those are the types of vaccines that we currently get, that we get every couple of years, that our children get as part of the pediatric vaccine schedule. But this vaccine, this mRNA vaccine, is new, so it will be added to the types of vaccines that we're giving people today. So the big question: are these RNA vaccines safe? Okay, so far, the adverse events that we have are short-lived. Okay, and we're going to hear a lot more about this as people who are getting these vaccines in the general public, our healthcare providers, as they start to report some of these as well. But we know from phase 1, phase 2, that most of these are short-lived. Headaches, muscle aches, fatigue, fever. Pain at the injection site is definitely something that a lot of participants are talking about. Okay, but I don't know about you guys, my arm was really sore after the flu shot. So after most of the vaccines that I get, I don't know, maybe it's because my arm is super skinny, but it hurts. It hurts a little bit. All right. So it's not uncommon. These are not uncommon short-term adverse events from really any vaccine that we might get. Now, we're still learning about the long-term effects. Keep in mind that these vaccines have only been part of the clinical trial since about March. So we're really only looking at that period of time right now. So we're actively monitoring this, but as of this point, we've only seen these short-term adverse effects. Okay, but we're going to keep these trials are watching for this. The phase 3 of these trials is 2 years. So they will be monitoring safety data 2 years into phase 3, and then even further as it moves into this other phase of the clinical trials. We informally call them the phase 4 as these vaccines go into the general public as well. So safety data will be continuously monitored on these vaccines for years and years. Some other questions that we'll get. Let's see here. Who qualifies to get the vaccines? Well, right now the Pfizer vaccine is there, and the Morderna will hopefully get approved soon. And when will I be able to get it if you want it? Okay, so right now, high-risk populations are getting the vaccines. These include healthcare workers in the emergency room, in the ICUs, respiratory therapists, for example, individuals in nursing homes and long-term facility residents, and the healthcare providers in those facilities. They are in the phase 1. In New York State, we have some phases. Every state is doing this a little bit differently. But for the most part, across the US, we're really prioritizing that these high-risk populations, these healthcare workers and individuals in the nursing homes are getting the vaccines first. New York State has vaguely identified groups in these phases, but the priority is going to be given to these high-risk populations. Phase 2, phase 3 will include others that work in various areas of healthcare. We'll also start opening this up to our first responders and other essential workers, grocery store workers, teachers. Hopefully teachers will fall into this group as well. Also people at very high risk, probably individuals over the age of 65 that have high risk pre-existing conditions. And so when it comes to phase 1, 2, and 3, these are the populations that hopefully throughout the rest of December into January, they're going to be able to get the vaccines if they want them. Probably not, the general public, these vaccines, depending on how long the Johnson & Johnson vaccine takes to get approved, the general public may not be able to qualify yet based on these phases until possibly February. Is where we're looking at, maybe January, depending on the numbers of vaccines we get and the availability. But December and January, these high-risk populations will be getting them. Now, the Pfizer and vaccines are 2 doses. So can you get COVID-19 in between the doses? All right, because you're going to get the first jab, the first dose, and then about 21 days, 4 weeks later, you get the second one. Well, a lot can happen in 4 weeks, right, guys? Especially if you're a healthcare worker. So can you get COVID-19? And the answer is yes. Yes. We do know that there has been about 9 participants in the clinical trials that shortly after receiving their first dose, just within the first couple of days, they did come down with COVID-19. They did have a positive PCR test. So what that tells us is that it takes several days to build the immunity. So you need to take, after you get your doses, especially that first dose, you still have to be careful. We need to give the immune system at least 14 days to start generating that immune response. Now, it could be that the first dose is enough to give us that necessary immune response that we need for protection. But the clinical trials, they've used 2 doses in their schedule. And so that's what we're going to use. And those are the guidelines that we're going to be following until they submit other data to us and the FDA can amend any EUA that they want to do. The vaccines are not 100% protective, guys. They're not. Okay. But they're greater than 90%. So that's pretty good. That's great, in fact. All right. So even though we've got these great vaccines, we still need to do our part. So if you get vaccinated, can you still spread the virus if you're exposed? Yes. All right. Now I put a question mark there because that data, especially from the Pfizer vaccine, it hasn't really been readily available to us, okay? The data has been provided in certain aspects of their phase 3 dissemination of their data, but it hasn't been published yet. Now, the Morderna vaccine recently released, just within the last day or two, data that shows that their vaccines do provide protection against asymptomatic spread. So that will surely help in reducing the spread, but because that data is still small and we still don't have that data from all the vaccines yet, for the time being, even if you've been vaccinated after the first and the second dose, we are going to encourage wearing masks and social distancing. All right, so we want to be mindful of that. Even though you get the vaccine, someone you know that has the vaccine, we need to continue to wear masks and carry out with social distancing. What about kids? Can they get the vaccines? All right, those are the big questions. We get those all the time. All right, Right now, the EUA for Pfizer is for ages 16 and over. All right, so that's some high school kids. So that's good news, and college kids. So they are approved to get these vaccines, and they will get them when in New York State, when the phases of the general public get them. Now, the trials, the Pfizer trial, the Morderna trial, Johnson & Johnson, they've all amended their trials over the last couple of weeks to now include children in the ages of 12 to 17. All right, so we have to wait for that data to see the safety profiles of the vaccines, because we have to modify some things for those age groups because their immune responses are a little bit different. They're a bit younger. And so we have to modify what we're looking at in the trials in those age groups. But hopefully we'll be able to get that data in the next couple of months. But just given what we know about the COVID-19 in children, the diseases aren't as extreme as they are in the older populations and individuals with pre-existing conditions. So definitely people over the age of 65 with pre-existing conditions are the priority. Here's the big question we get. And this is a question, guys, that we have to follow long-term here. Will we need to get vaccinated for COVID-19 every year like we do the flu vaccine? Regardless of the vaccine, are we going to need this? And the answer is we don't know yet. All right, this will really depend on how fast and if the virus mutates enough to where the vaccines that we're getting lose their protective efficacy. All right, right now what we know is that the virus actually seems to be really stable, okay? Based on other coronaviruses, MERS, SARS, okay, that we know of, they do mutate a little bit every couple of years, but they're not large mutations. So we're actively monitoring this. And what you see is an older picture of just an example of some of the groups out there globally that are monitoring the sequences of COVID-19, SARS-CoV coronavirus 2 that we have across the globe at looking at different strains, monitoring mutations. And now with these vaccines, they're going to be assessing whether the vaccines are still going to be able to provide that protection. So this is something that we're actively looking at. And fortunately right now, though, believe it or not, the technologies we use, like this mRNA technology, it does allow for quick revisions. All right, because it's using sequence data, if we do find that there is a mutation that requires alterations to the vaccines should be able to quickly modify and develop a new vaccine like we do the flu vaccine and to become available quickly. So that's hopefully that will be some good news that we can hear. Now that there are vaccines, can we stop wearing masks and social distancing? Big question, guys. I know, not yet. Hang in there, please. Hang in there. I know you can do it. All right. I know the masks, you got to wear them. I don't mind the masks. My kids can't stand the masks. They can't stand. I have a 3-year-old. She does not like the masks. All right. But we've got to do it. They just want to run up to grandma and give big hugs. Not yet. Hold on. All right. The idea is that we've got to establish immunity via vaccinations to about 70 to 80%. This number fluctuates. Some people say 90%, some people say 70%. The idea is to generate a herd immunity, okay? And it's tricky because not everyone's going to get the vaccine, right? Not everyone's going to get the vaccine. And that's okay. All right. But not everyone's going to respond to the vaccine as well. So we need to wait until levels of transmission in cases reach a certain level. And that's what we're waiting to see. And that until we get to that point, we really need to just continue to wear masks and social distance and do our part. If somebody's already had COVID-19 and they have antibodies, do they still need to get the vaccine? This is the big question I'm getting right now. And the answer is yes. Yes. All right. I can tell you that my husband's grandmother, so my grandmother-in-law, 95 years old, got COVID-19 a few months ago. Just had a fever, right? Just had a fever. She's so lucky. All right. She's getting a vaccine in the next couple of weeks. Why? All right. Well, what we're finding is that even though you've had COVID-19, some people have antibodies, some people don't. We don't know why. But when you get infected with the natural virus, you generate all kinds of antibodies. You generate antibodies to the spike protein, which we know is good, all right, but different parts of the spike protein. You generate antibodies to the matrix protein, to all these different components of the virus, all right? So it's kind of like a buffet of antibodies that you have going on in your body. And we don't know how good those antibodies are. Are they neutralizing? Can those antibodies provide protection? We don't know yet. We know that some people who have gotten COVID-19 can get it again. So what we're trying to encourage people to do is still get vaccinated, because we know that the vaccine, the antibodies and the immune response that the vaccine generates is protective. So we want that kind of double whammy, all right, that to ensure that we know for sure that whatever antibodies you have are going to provide that protection. We're still learning a lot more about natural infections, even about the types of immune responses that these vaccines are generating. But we know at this point, based on phase 3 clinical trial data, they provide that 90 to 95% protection. So we're going to go with that one. Okay. What about these vaccines? There's a lot going on about the storage. What is it about the storage of these vaccines? Why is it important? Well, these mRNA vaccines, these are tiny pieces of messenger RNA, okay? They're really finicky, okay? They're really sensitive to changes in temperature, changes in their environment. We need to keep them cold, very cold. All right. And so these vaccines have to be stored in very extreme temperatures. That's why you see pictures of these vaccines stored in these giant medical freezers. Okay. Minus 94 degrees for Pfizer, minus 20 degrees for Morderna. So that makes the logistics of this kind of complicated. So when we travel with these vaccines, they have to be in heavily refrigerated trucks. And so the storage of these can be problematic. And that's one of the things that we have to be careful about in disseminating and deploying these vaccines. Now, so the Pfizer and the Morderna vaccines do require very cold temperatures. You can take them out and put them in the refrigerator, but they're only stable for short periods of time. And so they have to be used quickly. So the logistics of the deployment of these vaccines and the dissemination does get a bit complex. We really need to be organized with this. The good news is that the Johnson & Johnson vaccine and the Astrazeneca vaccines, they can be refrigerated. So hopefully logistics of those vaccines will make things a little bit easier to disseminate when we get to that point of making it available to the general public. So what about these other vaccines? All right. The other vaccines, the Johnson & Johnson and the Astrazeneca vaccine, these are viral vector vaccines. What? Isn't this a vaccine to a virus? It is. So let's talk a little bit about this briefly, because I know I'm seeing lots of questions come in and I want to get to those for you. A viral vector vaccine, what we're dealing with these vaccines is it's basically the adenovirus. All right. The adenovirus, there's lots of different serotypes of the adenoviruses. Most of them just give us a common cold. Many of you out there get infected with the adenovirus every year and you don't even know it. Okay. So, but what they've done is they've taken this adenovirus, they've taken a couple of genes out of that adenovirus, and they've taken the spike protein gene of SARS-CoV-2, they've popped it in that virus, okay? And so it's a vector. It's going to have a little piece of the spike protein in it. And what we do is that we give the patients these adenoviral vectors, all right? And when this adenoviral vector infects our cells, all right, it's also going to express some adenoviral proteins, okay, but it's not replicating, okay, so that's good. So the adenovirus isn't going to replicate, but it will express the spike protein of the SARS-CoV-19 or CoV-2, okay? And so this is another way, just another mechanism of delivering the COVID-19 spike protein, all right? So it's a different type of vaccine. It's delivered in a different mechanism, but the outcome is the same. The spike protein gets expressed and our immune response is generated against that spike protein via giving us antibodies, neutralizing antibodies, IgG antibodies, IgA antibodies, and T cell responses and memory. Okay, so both of these vaccines have a very similar adenovirus vector. All right, the Johnson & Johnson vaccine, one shot, guys, one shot. Even though the clinical trials also include a 2-dose schedule, they're testing both of them, they are testing this in a one-shot schedule. That's huge. That's huge. You go in, you get your vaccine. Just for those of you that are in medicine or those of you that are getting ready to move into medicine, follow up with your patients can get hard sometimes. They don't always show up for their second dose or their boost. Okay, so that's a big part of the problem with some of these 2-dose vaccines. This one, so that's going to be a really, really big step forward. Now, Johnson & Johnson, this clinical trial, their original trial was for 60,000 participants. They've actually dropped that number down to 40,000. All right. And it's most likely due to the fact that they just have a lot of data. Usually these trials, they've added a lot of participants to their phase 3 so that they could get more data in a more expedited way by increasing the number, right? So you guys have heard about maybe in some of your, in your studies, you know, by increasing N, you're increasing the number of participants. So they probably have a lot of data and they were able to lower that number down to 40,000. Now the Astrazeneca vaccine, also adenoviral vector, still is 2 doses. And I had mentioned that the dosing schedule is a little bit off. And so we're going to have to wait to see what that data comes back. It is moving a bit faster in terms of getting approved in the UK than in the United States. So we may see that one receiving approval sooner in the UK. All right, guys, I just wanted to share some of the more common questions that I've been getting over the last couple of weeks and months, really. At this point, I'm happy to kind of close my screen here, stop sharing, and answer any of the questions you might have for me.
Well, Dr. DiCaprio, thank you very much. Very lucid comments, presentation, and over the course of the last 36 minutes, we've accumulated a whole bunch of questions. I will not be able to cover them all in the time allotted, but some of them are basically pointing in the same way, much the way all of your different vaccines are going after that spike protein one way or another. So we're going to go after this one at a time. Let me mention a couple. You did touch on this, but could you say a few more words about long-term side effects? To what degree could some of them be autoimmune and perhaps stimulate the progression of underlying autoimmune disorders? And what time frame beyond the 2 years that you mentioned do you suppose we will still be looking for these long-term side effects? I know that's an unanswerable question scientifically, but what does your gut tell you?
Those are great questions, and those are common questions, and they're important questions. You know, as far as the long-term effects go, as it relates to autoimmune, those are definite possibilities. We actually see them a bit more common when we're talking about vaccines against viruses. There could be reactivation of autoimmune diseases. There could long-term lead to the development of certain autoimmune diseases. And we just don't know at this point. And so what will happen is that these vaccines, even though the trials are set for a 2-year period for phase 3, when vaccines get officially approved by the FDA and they're approved for dissemination, so this isn't an emergency use authorization, what'll happen is that the vaccines will be disseminated to the public and they'll be available to people for many, many years. When adverse events are recognized, physicians or the primary care provider, whoever, they report those. So there's actually a dashboard through the FDA where physicians can report these side effects, any and all side effects. So for every vaccine, the flu vaccine, we're actively doing it for the flu vaccine and the MMR vaccine and the diphtheria vaccine. We never stop collecting data on long-term effects when it comes to vaccines. So if something should pop up 5 years down the line, that information gets reported and it will be logged with that vaccine as in terms of adverse events.
Thank you for that. And I would also add, as somebody who's worked with vaccines for many years, let's remember that an event after giving a vaccine may or may not be related to the vaccine itself. Also, let's sometimes think of these not necessarily as adverse reactions, but as evidence of the actual immune response, which can be laudable. This can be a good thing. Difficult to sort out at the time it's happening, but with good data collection, good monitoring, we can often draw valuable inferences on what really is an unwelcome side product of vaccination versus something that just happens in time or something that's a sign of the immune response. Speaking of responses, there's another question. And by the way, for those of you who've sent in questions, some of you sent them in anonymously. Some gave us your name. I'm not going to give the names of any of the people asking the questions to protect your privacy. So this next question is, what are we going to say to someone who has a history of allergic anaphylaxis to some other vaccine? Are we going to recommend that they not get vaccinated or that they should get vaccinated?
That's a great question. And as for right now with the Pfizer vaccine, the recommendation is that if someone has a history of severe anaphylactic responses, allergic responses to vaccine, we're really recommending that they not get the vaccine. And given, I think that there is going to be some wiggle room there for those individuals because it is their choice. And they some recommendations have also stated that should they want to get the vaccine and have that history, they should be monitored for a period of time, usually about 30 minutes following the receipt of that vaccine, should they have any major allergic responses. It was more of a just kind of like a heads up when it came to the Pfizer vaccine, and it's likely to be very similar with the Morderna vaccine because we do see some allergic reactions with these as well as we start to disseminate to a wider demographic of people. So those individuals, it will, I don't think that they're going to say, no, you can't get the vaccine, but they will be educated and they will be able to provide consent to the vaccine should they want to get it. And they will just have to go through a period of monitoring so that we can provide appropriate medical care should they develop an allergic response that requires medical care.
That's a great comment. And I would add that let's remember that a vaccine recommendation is made for almost an entire population, or at least a defined subgroup of a population. This does not mean that every single person should be vaccinated. There are always some exceptions. And remember that in making a broad population-based recommendation, there is still room for an individualized medical assessment and an individualized judgment for the benefit of an individual patient, whether that person should be immunized in some way. Let's remember too that getting immune to a disease can be in many ways much more valuable to the patient than continuing to have risk to that disease. So the decision to vaccinate is made for the population, but also for some individuals when you consider what is their risk of getting sick with COVID and possibly going on to more serious complications, and balance the risk of the vaccine versus the risk of disease. Thank you. Great question, great answer. Now, here's an interesting question. They're all interesting, but this one really catches me because I used to do all these vaccine efficacy calculations at the CDC. It's claimed by the questioner, I don't know the data, that it might be a little too soon to boast a 95% vaccine efficacy when since lots of people were vaccinated, but only a relatively small number actually got challenged with wild infection. Pardon me. The questioner is saying that only 170 actual trials or data points of exposure to wild infection occurred during a particular trial. So if the numbers, because remember, you only know vaccine efficacy when somebody gets exposed to the wild virus. Do they get sick? Do they not get sick? With that lower number of people of actual observations, are we boasting a little too soon about vaccine efficacy? Seems like a fair question.
It is a fair question. And I'm not a statistician, but there were a lot of statistics that went into generating the necessary numbers, the identifying the confidence intervals, identifying what the threshold was. All of these trials, the FDA had established a 50% efficacy as a requirement for all of these vaccines. And so some of them are very close to the 50%. Some schedules of the Astrazeneca vaccine are closer to 60%. But in looking at the statistical algorithms and the equations that they generated for these trials, these numbers fit well, and they were able to demonstrate efficacy based on those statistics. And as I said, I'm not entirely sure what those statistical properties were and how they really relate to the numbers. It does seem like a small number of cases, being only a little less than 200 of those cases. But given that those statistical algorithms and requirements, they did meet those thresholds in providing such a high percentage of efficacy. And you also want to remember that given those numbers, the individuals that receive the vaccine, these individuals, they did not get the disease. This is a heavily contagious disease. And in terms of looking at weighing out the risks and the benefit to this, it really just kind of it all favored moving this forward with that efficacy. And I'm sure that as time goes on and data is collected more as part of this phase 3, because remember, phase 3 is continuing on. The placebo group and the vaccinated group, they're continuing to collect data, and that number may fluctuate as months go on, and we start to acquire more data using that those statistical equations and meeting those requirements.
That's right. And let's remember too, the whole goal of this is to reduce the circulation of virus in the population. And the ultimate empirical result is that there's decreased transmission, and the world, which currently is awash in SARS-CoV-2 infection, will see a recession of that wash and turning back of the tide, so that it will become a regional infection, and then perhaps limited to just a few countries or parts of the world. We will see this thing snuff out faster than it would if it were left to its own devices. Now, here's an interesting proposition. Dr. DiCaprio, you mentioned earlier that someone with evidence of prior infection should still be vaccinated, because who knows what kind of immunity they got from the wild infection. It may not be neutralizing kinds of immunity. But what would you say to somebody who is actively infected right now, who got a PCR test, say 3 or 4 days ago, and it was positive, and you know that they've got active infection? Should they be vaccinated? Is it safe for them to be vaccinated? And do we really know?
I love that question. I love it because what that really highlights is the need to kind of evaluate these vaccines as therapeutic vaccines. There are some vaccines out there, like the rabies vaccines. I did work with Ebola and Marburg vaccines and actually studied these vaccines in that capacity, to actually have a vaccine that serves as a preventative measure, but also a vaccine as one that can be prophylactic and therapeutic. And the answer to that question, at this point, we do not know the answer. These vaccines are not being studied in that capacity right now. They will be eventually, it's likely. So at this point, if someone is actively infected with and is demonstrating symptoms of COVID-19, the recommendation is probably not to give them the vaccine. We're still trying to get our hands on the adverse effects. One of the things that we're finding in terms of the disease is that it is overwhelming the immune response. Okay, so very similar to something we see with sepsis, we see an enormous increase in inflammatory cytokines. The innate response gets very high. We see lots of these overwhelming responses to the virus itself that cannot be stabilized and returned to homeostasis, which makes it difficult for us to stabilize the patient. And so to have somebody who could be right at that cusp where they're balancing their host response against the virus that's actively infecting them, to then give them a vaccine that, even though at this moment has adverse effects, is going to really stimulate the immune response, we may tip the balance in favor of the actual virus itself, the SARS coronavirus vaccine. So we don't know yet what would happen. And so it's not something that is recommended. It may be in the future though. And it's definitely something that should be looked into, because some of these vaccines that are very potent at developing strong innate responses could be very good at going after, especially these RNA viruses. We've seen it before, and so it could be a possibility in the future. Very good question.
These have all been great questions, and Dr. DiCaprio, as usual, you do not disappoint. We've got a little bit of time for maybe a couple more if you're still going strong, and I think you are. Okay, great. So here's one I did not think about. I don't know why, but this person says the Corona vaccine from Sinovac Life Sciences is showing 90% efficacy as they finalize phase 3 clinical trials. Now, this is an inactivated virus vaccine, and I'm taking that to mean this is an inactivated virus, just like the inactivated polio vaccine, the original Salk vaccine, or IPV, which is now used routinely in the United States instead of the live attenuated vaccine, even though live attenuated is still used with good reason in certain other parts of the world. But I guess the question is, next to these other more modern approaches, is there any reason not to use an inactivated virus vaccine?
No. At this point, when we look at these different types of vaccines, if it's safe, if it has efficacy, that's all that we're looking for. Whether it's inactivated, whether it's live attenuated, whether it's an mRNA or a viral vector vaccine, there are, what we're really going to be looking at when these vaccines move through clinical trials: safety, immunogenicity, and efficacy. If they're able to demonstrate an appropriate safety profile, they demonstrate that they're able to induce a strong immune response that is effective at minimizing the disease, stopping the disease, there's various parameters that we're looking at with these different vaccines, then they are worth looking further into and considering moving forward with the FDA. It's not about whether one type is better than the other right now. Any and all types are being evaluated. We have some weakened vaccines that are out there. We have inactivated vaccines. They have subunit vaccines. There are over 40 different vaccines across the globe that are actively being evaluated. The 4 that I talked about in this presentation just happen to be the top 4 in the United States, but there are other ones that are actively in clinical trials and being assessed as we speak.
Wonderful answer. Again, we all know that, or perhaps some don't know, that Touro is not just a New York institution. It is not simply California, Nevada, or all of the other locations. It's really an international institution. So this is going to be the last question, which has international implications. This, of course, has been a race to the top in this country, in the UK, but also a race to the top in other parts of the world. How do you feel about the many other vaccines in the world, such as those that have been produced in Russia, China, and the questioner is saying Dubai? I was not aware of that. What is the difference between these other countries' sourced vaccines and the current Pfizer vaccine or any of the others that you've been speaking of this afternoon?
Great question. Most of the vaccines out there, one of the common themes that we're seeing globally is that they are all targeting some aspects of the spike protein. Some are doing the entire spike protein. Others are really narrowing down on very specific areas of the spike protein. So that is one instance of similarity that we see of the vaccines across the globe. The formulations, okay, so a lot of that is proprietary based on the pharmaceutical companies that are making them. So there are going to be some differences in the formulations and the developments of these vaccines. Some of that information is proprietary and is not freely available until they're approved. But I think what really is most important when it comes to these different vaccines is the regulatory processes and requirements in the different countries that are necessary to approve those vaccines. In the United States, we have the FDA. Every country does it a little bit differently. Every country has access to different scientists and different types of science and just resources. And so you're going to have that diversity and that variability across the globe. Now, it's important to also mention that Pfizer, for example, Pfizer is carrying out vaccine trials all over the globe. They have in many different countries. So even though we're talking about the Pfizer vaccine and its trial in the United States, it is carrying out trials in 3 or 4 different countries. So is Astrazeneca. So these vaccines are being carried out all over the world, and that is to facilitate clearance through those countries' proper protocols so that those countries can decide based on that data if they can get approved.
Thank you. That is wonderful. I'm going to slip in one last question from one of my favorite people on the New York Medical College campus who would like to know, what is your comfort level with your own children eventually having the vaccine when the time comes?
Oh, everyone's got to ask that question. But you know what? I'm happy to share that I am more than comfortable at receiving the immunizations myself. As well as my children. I think I will point this out there as a personal and kind of one of the opinions that I hold, that I will admit I haven't done an enormous amount of research on this, but it is a question that I need to actively research myself. These adenoviral vectors, they are an adenovirus. And so one of the things that I'm curious to see, and I hope that these clinical trials demonstrate data, is whether or not these vaccines induce neutralization or an immune response to the vector themselves. If we are going to get infected with the adenovirus carrying the spike protein of SARS-CoV-2, will these patients generate an immune response that could potentially neutralize future vaccines? My daughter had a very nasty case of pneumonia a few years ago, surprisingly being caused by adenovirus. Now, there are hundreds of strains of adenovirus. I recognize that, but that is one thing that as a parent and as a microbiologist, I do wonder, will that vaccine not work so well in her if she has residual immunity to adenovirus? So that is one question that I hope we receive data on when it comes to viral vector vaccines.
So thank you very much. In closing, I just want to remind folks, this has been recorded. And so for those of your colleagues who missed it, they can still access it at New York Medical College. This is New York Medical College, but also Touro. And just to remind each other that until the vaccination programs fully take hold in our populations, we are still left with the non-technological parts of the response, which are the 4 W's: wear your mask, wash your hands, watch your distance with others, and walk away from clusters of people. Don't stay in groups of people for longer than you really have to. We thank you all for joining. There have been just under 100 people on this call and some 20 questions. So that's a 20% question rate to match our 95% vaccine efficacy rate. Thank you all, and tremendous thanks to Dr. DiCaprio. You are always welcome in person on the campus of New York Medical College in beautiful Valhalla, New York. Thank you, everybody. We're going to close up for now. Everybody, please stay safe so we can make it to the next webinar. Thank you.